Good afternoon, or actually technically good evening. I'm behind a couple of hours, it seems. But welcome to our second round of menopause and perimenopause webinars. We have another one that is scheduled in September. If you have not already registered, please do. Let me take a minute to introduce myself for those who don't know who I am. My name is Schquthia Peacock, and I am a family nurse practitioner, and I practice at Avance Care Preston here in Cary. So welcome, welcome. I'm glad that you are able to join us today. And thank you for your patience as we were getting the slides set and ready. So for that slight delay in getting started, but I promise you it will be well worth it because we have lots of information to share. For sure, for sure. So I wanted to take a minute to introduce myself and kind of give you an idea of where or how I became interested or kind of forced to learn more about menopause and perimenopause. And that's because of my own journey through the symptoms around menopause and perimenopause. And the unfortunate part, as many of us experience, is that we have some struggles in finding information. So I took it upon myself to educate myself around menopause and perimenopause and the symptoms that I was experiencing to give my women's health nurse practitioners and primary care providers some education about the symptoms that I was feeling. So I wanted to make sure that then I can share that with my patient population and the community. So that's what's led to this webinar series and doing it for the second time because I thought it was time to revisit it, especially with all the information around hormones being shared in social media. Wanted people to have a reliable source of information and a place where they can ask questions openly. All right, so we're going to kind of keep this as informal as we can as a webinar. We will have a moment for questions to be shared within the chat. And I think there is a chat that will be accessible for everyone to display questions if they choose. All right, so now let's move over. Let's take that to our next slide. So start with a little bit of information around menopause and what that is. So menopause is a set of symptoms, and actually let's start with what we're going to talk about. So it's going to be a definition around menopause, diagnosis, common symptoms that are present, and those that may be not so common. Hopefully you can help me with some of those not so common symptoms. I'm showing you a hormone transition timeline, as well as symptom comparisons and going over some management considerations, especially around insomnia and hot flashes, because they seem to be very disturbing to many women in my patient population. So what is menopause? So menopause is defined by having 12 consecutive, and keep in mind that's consecutive months of what we call amenorrhea, or not having a menstrual cycle. And that would include spotting to heavy flow, so I would put all of those in the category of menstrual period. So that diagnosis is provided after 12 months, consecutive months of not having a cycle. So you start, let's say, for instance, you had not had a cycle since May of this year, and this would be into your third month. Then you need to wait until May of 2026 before you would consider menopausal. Keeping in mind that menopausal is just one day in time. Anything prior to that is premenopause, and anything post that is postmenopausal. A little bit of demographics around that is that the average age of menopause is about 51. In the Caucasian population, that age is a little less in those that are African American, Latino, Hispanic, and Asian. And that can be even as early as the late 40s. So keeping that in mind is that most people may have symptoms that are not classified as menopausal by the age of 51. It may actually happen earlier. And again, it is diagnosed retrospectively, 12 months prior of not having any cycle, the amenorrhea. And it's caused by a lack of follicle activity and lower estrogen and progesterone levels that lead the ovaries not to produce a follicular, have follicular activity or produce a follicle that then turns into an egg that would be implanted into the uterus. So during that period of time of menopause, if that follicular activity is not happening, there is not an egg to be fertilized, and so therefore the ability to conceive is not present. So that's one of the reasons that we want to make sure that that diagnosis is there, because there's a lot of fluctuations in hormone around menopause and perimenopause, and those are times that you could still actually become pregnant if there's actually follicular activity. So that 1 year of consecutive, 12 months of consecutive not having a period or amenorrhea would be that definition, signifying that your ovaries are not producing eggs and therefore not leading to the ability to conceive. One piece that I wanted to add, and we may get into this in some of the slides that are upcoming, but most of those perimenopausal symptoms can start, 8, some people even 10 years prior to the onset of menopause. So that takes people into their 40s or their 30s, in some cases, with perimenopausal symptoms. All right, so let's start with a little bit of get to know who's in the room. Who's in the room? So tell me, where do you live? I already put where I live, even though I probably spend more time in Cary at Avance Care Preston, but I actually live in Durham. So if you take a moment and scan that QR code or type in that forms, I don't actually think that this link is going to be live enough for you to click that copy link. But if you scan that QR code, answer that question, and tell us where you're from. Let's see how far we're spreading across the area. So Rayford and Apex and Florida. Actually, hold on. Let's see if we can get our slides back as it's loading. Florida is there. All right, hold on. Let me go back a slide or two. All right, so Cary, Idaho, Clayton, Raleigh. It's still not going down. Let's see with that cursor. Maybe it'll do it this way. So we'll just call them out. Any others in there? So it looks like farthest away is Idaho. How about that? And Florida. I think Idaho might be further than Florida, though. All right. Well, glad to have you in the room. Thank you for taking time to learn more about menopause and perimenopause, especially in a typical female's life where life is quite busy in the evening. All right. So now tell me age range. So I put 30s, 40s, 50s, 60s, 70s. And if there are some that are in the 80s, my apologies, but I was hoping that maybe you've already transitioned through and having a calmer side of life in postmenopausal life. So let's see. So it's some 40s are picking up there, 50s are too, some 30s are there. So certainly some perimenopausal women in the room, as well as menopausal, I would imagine. Awesome. All right, so have one more questionnaire there. Looks like we're still tattling in there a little bit. So we're going to move on to our next poll. And how many of you have heard about the I Don't Care Club? I love this lady on social media. Her name is Melanie, and she is followed. I follow her on Facebook and social media, Just Being Melanie. And so she has this following that talks about what we do not care about. And so one of the things that I put that I don't necessarily care about, which has come up this weekend for me, is that I didn't care if my husband was cold. I just didn't care because I was hot. So a quick little story there while you're plugging in some of the things that you do not care about is is that I was standing beside my husband at his computer, and I was overlooking his shoulder, looking at something on the computer screen. And he said, can you just back off a little bit? Can you back up a little bit? Right? And I said, what's going on? He said, well, you're hot and I can feel the heat coming off of you. And I said, and I did, I kind of backed up a little bit because, I know I'm hot in many ways, huh? So, and I explained to him, I said, because I am hot and you're not, I think that's a good time to educate you about how hot I am when you're not. So when you're cold, that heat is still coming off my body. And I need you not to touch the thermostat when I regulate it down to cooler. So that was a nice teachable moment for us both about understanding my body temperature in this period of change. All right, thank you. So we had don't care what others think about me. I like that. Exactly. I don't care if I wore the same jeans 3 days in a row, and I don't care about working in the office, going back to the office to work. I love that too. And I love that I'm wearing the same jeans 3 days in a row. Who knows? I think no one. I say go with it. It's not that serious. The other thing that I do not care about is whether or not I have a bra on or not, because bras are hot. So if I'm in the office, I typically have one on, but if you see me around town, I may not, and I don't care. All right, so now let's get back into our to our next survey. And so that is around what stage of menopause are you? I'm going to make that a bar so that you can see it better. So not experiencing any symptoms of menopause or starting to have changes, which may actually be that perimenopausal phase. In menopause, meaning that you have had that 12 months without period, and postmenopausal, meaning that, that's the time that's after that 12 months of being without a cycle. And then not sure. There's many of us that are not quite sure exactly where we fall in that scheme of things. I know for quite a while, I wasn't aware that I was even in perimenopause. I just knew that something was not quite right, and I couldn't put my finger on it. Luckily, I had a healthcare provider that was willing to listen. She may not have had all the answers, but at least she was willing to listen. Good. I also think that with the amount of information around hormones, perimenopause, and menopause that are out there, a lot of people have acknowledged that these symptoms could very well be perimenopause and menopause. So I'm excited about that. Because we have a better knowing of our symptoms and what could be affecting those. All right, so let's talk a little bit about that what happens in menopause. So estrogen, which is a main ovarian function hormone, drops, and mainly estradiol that makes up that estrogen component. Also, progesterone falls, which is another hormone that's produced by the ovaries. That leads secondarily to FSH and LH increase. FSH and LH are both hormones that your brain produces to tell your ovaries to produce more of the estrogen and progesterone. So if your brain is sending a big signal to your ovaries to push out more estrogen and progesterone, it's sending more and more of the FSH and LH. Both of those hormones can impact menstruation or menstrual cycle, sleep, metabolism, and mood, and are very much correlated with those hot flashes that many of us experience. And I would say the estrogen and progesterone can have an impact on hot flashes. I find that usually that progesterone decrease may happen first, and then estrogen follows in many women. So estrogen was what we really associated with that menopausal transition. And I find that that decrease in progesterone is maybe what happens first in the perimenopause transition. All right, so now let's go to our next slide. And here we have that menopause transition. We talked about perimenopause could happen 4 to 8, I think in some cases, maybe in 10 years prior to menopause, meaning that 12 months of not having a cycle. And it's it's an up and down of estrogen and progesterone. And it's kind of like throwing a dart at a dartboard, and hopefully maybe you can catch a time where those numbers are up or down. So oftentimes we do check hormones, but to understand that when we are checking hormones, Hormones are not going to tell us whether or not you're in that perimenopause and menopause phase because they're going up and down. They're going to be normal sometimes. They're going to be elevated sometimes. Sometimes they may be even unnecessarily or uncertainly lower than what is therapeutic for those ovaries to produce an egg. But at any point, they could fluctuate back up and an egg can be released, leading to the ability to conceive. Remember, postmenopausal is 12 months without a period, and that's meaning that you have consistently low estrogen and you're not producing a follicle or the egg to be implanted in the uterus. Hormone changes shift constantly. And one of the things that can lead to that shift being more drastic is around fat storage, where we're doing with our muscle mass storage as well as insulin sensitivity. Insulin sensitivity becomes more of a challenge, and we're going to get into that more in our second webinar when we talk more about weight. And of course, knowing that estrogen being low could lead to hot flashes. Progesterone being low could lead to hot flashes and certainly has a lot of a correlation with insomnia. All right, so our next slide. Common symptoms of menopause transition. Everybody knows so very much about hot flashes. I was talking to a lady today. She may actually be on the call, on the webinar. And the idea of dripping with sweat at work, in front of coworkers. That certainly has a major impact on our body image and our being comfortable in our work environment, and can lead us to feel less than or inadequate in cases, which I hate that happens, but it is a common symptom that we face as women in the workplace. Sleep disturbances and insomnia, major symptom, very disruptive and disrupts the quality of our workday and the quality of our relationships. Mood changes, anxiety, depression, irritability. Could certainly go back to those hot flashes and that sleep disturbance. I certainly get irritable if I didn't get a great night's sleep. Weight gain and altered metabolism, very much a major impact. I have come to accept that my body is different than it was in my 30s. And I have to appreciate that this new body is where I live now, and I need to protect it and keep it healthy with my regular diet and my regular exercise. Vaginal symptoms are sexual concerns. So vaginal dryness, changes in libido, changes in ability to achieve orgasm at the same rate or at the same intensity, cognitive complaints. Brain fog. Oh my goodness, if I have not forgotten a word, I have not forgotten a word. I actually saw a reel of a lady who was saying that she was her menopause counterpart was sitting on her shoulder. And that menopause counterpart had all her words in a jar. I thought that was hilarious because I think all of my words that I cannot find are in this jar, and someone is holding them hostage, and I need to pay a ransom and get them back. So that brain fog is a major component, and again, very impactful for our work and our ability to do the things that we need to do throughout the day. All right, so then next we have, let's go to our next screen, and thinking about that hormone loss. So we talked about those numbers fluctuating up and down, but over time, your estrogen, which is in the kind of like more of the lighter orange line, and then the progesterone in the darker orange or looks like more of a tangerine line, start to deplete. So reproductive years are here, early perimenopause here, and as I mentioned before, progesterone drops first, estrogen does second, and then late perimenopause as we're going to enter into menopause, which is going to happen in here. And then after that first that first 1 year of not having a cycle, we enter into what we call early postmenopause. And then late menopause, both of them start to fall down low. Estrogen being one of the later ones to fall off to not being measurable. Late menopause, that may still be in the 50s for some, depending on when this process started, right? Depending on when that process started. But I wanted to use this to point out that your progesterone may actually fall first, right? And that variability in those numbers are very much noted in the perimenopause phase. and could lead to those hot flashes and sleep fragmentations and mood changes and metabolic shifts like metabolism shifts. This is a great pictorial also. I liked it because it shows based on age where our estrogen is higher and lower in our age range. And so this is in our 20s and 30s, reproductive years, 35, also reproductive years. We're getting toward the latter part of being considered a optimal time for fertility. And then into our 40s where those numbers start to fall off. And you can see perimenopause is kind of benchmarked here, kind of within a good age range. It may actually fall a little lower, closer to 40, as those estrogen levels start to fall. I want to point out is that in some people, they may have actually an increase in estrogen in that perimenopause phase, as they notice a decrease in the years to come. All right. Next, looking at frequency of common symptoms. So hot flashes coming up there at 60 to 70%. Most certainly one of the major symptoms. Falling in second is insomnia, very disturbed sleep. I was up early this morning too, as maybe many of you were. Mood changes, fluctuations in mood, like I said, likely could be related to my lack of sleep, but my irritability and tolerance to things have certainly been compromised. Certainly more tolerant of things in my 30s than I was in my 40s and 50s. Metabolism, physical body image change, vaginal symptoms. This is another list of some of the common perimenopause symptoms and give you an idea of what the percentage of people who have those symptoms. So about 20% of women may be asymptomatic through perimenopause and not necessarily even know that it's going on. But by far, the majority of people may actually be having symptoms. About 30% of people only have hot flashes, and about 70% have hot flashes plus something else, right? And that can include mood changes, sadness, even suicidal ideation. There's an increased risk of suicide in that perimenopause phase. And we can understand the frustrations of not knowing what is going on with our bodies. So I think this is our first step in understanding the symptoms of menopause and perimenopause to help us to find a place to express the concerns around those fluctuations in mood. All right, common symptoms of menopause, right? Oh my goodness. Hot flashes, sleep disturbances. We talked about this. I talked about irritability and anxiety, depression, weight gain, and that slower metabolism. We talked about the vaginal dryness and low libido, or change in ability to achieve orgasm or intensity of orgasm, cognitive changes and that brain fog and memory concerns, fatigue and joint aches. I wanted to make sure that I brought these up because fatigue and those joint aches, the changes that we feel around our joints and inflammation as estrogen drops off are impressive. Hip pain, knee pain, back pain, small joints in our hands become more achy and stiff because estrogen is an anti-inflammatory agent. And as it falls off, inflammation control becomes a challenge. And we have to work harder at controlling inflammation in our menopausal years, which means that we need to pay close attention to how we treat our body and what we're putting in our body to help control inflammation. It's not as easy anymore. All right, so we're going to go over some strange symptoms of menopause. So I wanted to ask, I put in my strange symptom of menopause, and that was itchy ears. Do you have some strange symptoms of menopause that, you wonder, like, what is this? Could it be menopause or perimenopause? Or I heard this is happening, and had no clue that it could be a potential symptom of menopause or perimenopause. Are there any of you want to add? I know mine are itchy ears, and if I could get in there with something, I could, but we know we're not supposed to put anything in our ears that's bigger than our elbow, so no Q-tips, no bobby pins, no pins, no, paper clips, nothing like that should go in our ears. All right. I'm going to show you some of those symptoms. Looks like heartburn. I like that. That is one of the ones. Could also be related to the change in our our abdominal area starts to increase in size and maybe putting pressure on our stomachs. All right, thank you for sharing that. Right, so now let's move over and CRS. Oh my goodness. Regional pain syndrome, I believe, right? Hives. I had actually a major experience with hives in my perimenopausal years, and it was related to that inflammatory response that was going on in my body. So I really needed to pay close attention to what I was putting into my body to lessen that inflammatory response. It was actually pretty impressive. And now much less hivey, that's for sure. All right, so let's go over some of those strange, unexpected symptoms of menopause. So burning mouth syndrome. I've seen many females with this, a burning, a tingling, metallic taste in their mouth, a coating that goes over their tongue, very disruptive in their ability to enjoy food or even rest because it's something they feel at all the time, at all times. Oh, feeling like something's crawling on your skin. I was doing this just yesterday. Like, what is that on my arm? Is it a bug? Is it a mosquito? But it was just a sensation that something was on my arm. It's tingling, ringing in the ears. Tonight, excuse me, ringing in the ears. Tingling is actually one of the symptoms too, though. Changes in taste and smell. I smelled strange things. Like, is that something burning? Like, what is that? No one else could smell it. Electrical shocks are sudden jolts of things shooting through your body, or feeling a wave of heat that goes over your body. I think still different than a hot flash, but just a wave of warmth that's very transient. Itchy skin. That's where I was putting my itchy ears. Hair changes, nail changes would be in there too. Changes in vision. Mine has been around dry eyes because moisture, not just in your vagina, but also moisture in your mouth and your eyes could be compromised when hormones are challenged. Digestive bloating, food intolerances. We talked about joint pain, tingling in your hands and feet, brain fog. We talked about previously, irritability, anxiety, and panic. My goodness. I have seen many women that have fears that were not some that they experienced before. Fears around driving, fears around flying, fears around something something going wrong with their children. That is something that also picks up during those perimenopause and menopause years. ADHD symptoms. A major period of time for diagnosis is through that menopause and perimenopause phase. Because of that brain fog and trying to find our words and feel like we're not optimizing our work capacity. Heart palpitations, body odor changes, sweating. Oh, I went through that major part of sweating in the middle of the summer. Oh, it was miserable. Changed deodorants 5, 6 times to find one that actually worked, that I felt worked at least. Dental issues, going back to that dry mouth. People can end up with increasing cavities. So we have to be careful about that. Let's see. Then let's go over to our next set. And giving you a little bit of a percentage of those hot flashes again. Hot flashes and night sweats are common about 85% of women, and that's about 143 million women. 85% of those are experiencing hot flashes, right? 64% experience sleep disturbances. So those both are major symptoms of the um, of the onset of menopause. So those were the two that I were really going to focus on and trying to give you an idea of what we can do about it. All right, so again, insomnia, especially waking up in the night, is a major symptom of menopause. What time do you typically wake up in the night? Do you typically wake up in the night at 2 or 3 o'clock like me? That is actually a common. I should put my questionnaire, fill out my questionnaire too. 3 a.m., yes. I'm a 2 to 3 a.m.er for sure. I'm not always easy to go back to sleep at all. I jokingly tell people when I hear this all the time, we can have a meeting at 3 o'clock in the morning because we're all up. All the women are up at that time. And that is related to that being able to calm our sympathetic response. Insomnia is a major symptom, and waking in the night and not being able to settle ourselves to go back to sleep. I can wake up at 2, 3 o'clock in the morning and feel like I need to get up and, head off to work, knowing that that is not going to work out well come 3:30 in the afternoon. I'm going to be tired. With it, probably even problems with being focused and distracted, having more brain fog because I didn't get a quality night's sleep. Sleep problems are common in perimenopause and menopause. We talked about that. Main drivers are those hormonal changes with the estrogen and progesterone, hot flashes. How many times have we kicked the cover off at night or gone to check the thermostat to make sure it's actually working? To mood would be also a major problem that can impact sleep around anxiety and worry. And I wanted to mention joint aches and pain too. That is another major symptom that people have to have comfort in order to sleep. So it may require actually taking an approach to manage discomfort through that menopausal transition. Some of the first line strategies around managing the insomnia or sleep is doing regular exercise. We prescribe medications often, and we refer people to behavioral health specialists to look at cognitive behavioral therapy for insomnia, trying to retrain our brain to go to sleep instead of think during the night, which is actually something that you can do on your own. There's lots of ways that you can do that through some online technology. Even though I try to have people really moderate and keep their online technology minimal during the night, sometimes using your phone for an app to help you with some of that cognitive behavioral therapy and relaxation measures to kind of turn our brain off. All right, so sleep hygiene, also a major. Cooling strategies. I've heard that there's a mattress pad that has a cooling agent to it, can blow cool air. If I could find a way to have that just on one side of the bed, I think that would be awesome. I have a little USB fan that I can actually sit in the bed with me if I need to, but it sits at the bedside and I can have it blowing directly on me if I'm having a problem regulating my temperature at night. Making sure that we're eating a proper diet. Staying away from things that are processed, high in fat and sugar, because they can trigger more of the hot flashes for a lot of people and cause insomnia too. Having too much sugar in our evening meal or throughout the day can lead to some of those early morning awakenings. And for me, having a missed lunch is actually a major trigger for me getting up at 2 or 3 o'clock in the morning, which is a common, unfortunate circumstance in many of my days. However, I do have what I always call emergency food. So there's my little bag of nuts that I keep on my desk that I can have for emergency food for my lunch if I don't get a chance to have a formal lunch in the kitchen. Exercise, so a combination of aerobic and resistance training can help with keeping our muscles and our body fatigued enough so we can sleep, as well as helping some with the metabolism. Mindfulness, cognitive behavioral therapy techniques, and social support can be very good at managing the stress that come as a result of the symptoms of menopause. Things like alcohol and caffeine and nicotine may actually be more of a problem than beneficial in managing sleep and hot flashes too. So alcohol can actually make both of those worse. And caffeine, of course, could too, especially when it comes to disruption of sleep. Trying to keep those minimal. Sleep hygiene checklist. A couple of things to keep in mind around sleep is keeping your sleep and wake cycles constant. Having a set sleep time and a wake time. Keep the area cool and dark. Keeping the bedroom quiet. Trying to avoid technology in the bedroom. Avoid heavy meals close to bedtime, alcohol and caffeine. Trying to do that no early and no later than no closer than 4 to 6 hours before bedtime. Screen time, keeping that 30 to 60 minutes before bedtime without any screens. Try to keep blue light filters in place. I use blue light glasses to help with that stimulation too, for late night or for documentation at the end of the day. Use the bedroom for sleep and intimacy only. Try to avoid TV or work in the bedroom. Good thing to consider. Always good. Cognitive behavioral therapy. There is a great avenue. That is a great avenue to help with regulating our sleep and training our brain again to sleep instead of think. considered first-line behavioral health therapy for insomnia, could help with controlling stimulus, and cognitive restructuring and relaxation measures are components that make up that cognitive behavioral therapy. Very effective in improving sleep onset and continuity and helping us to get back to sleep if we wake up in the night. Of course, I would want to include something around hormone replacement therapy in here. Hormone replacement therapy is a viable option for many people, but it's something that you should certainly have a conversation with your primary care provider about if it's something that you're considering, to see if that's something that you're a candidate for, and to make sure that you've discussed the risk and benefits associated with it, because that's a shared decision-making option for women who are experiencing hormonal-related symptoms. There are some non-prescription options for non-hormonal options that it should say non-hormonal prescription medications for hot flashes. So we use some antidepressants, SSRIs and SNRIs to manage that. Pregabalin and gabapentin to also help. Oxybutynin is something relatively new on the scene around hormone or hot flash regulation. It's a medication that was used mostly initially for overactive bladder. Clonidine is another hot flash regulator, sometimes used for blood pressure. And Vizolintent, which is Vioza in its brand name, is a prescription drug that's out for maybe the last 3 to 5 years that's targeted solely for hot flashes. Not always very easily covered by insurance, but it is a viable option for those women who are having significant hot flashes. Supplements and complementary options, and thinking about what the evidence shows. So phytoestrogens could help bring up estrogen, but keeping in mind that first May fall is not estrogen. You saw that on that graph before, estrogen may actually be dominant. So having some guidance of whether or not that's a good option or not, depending on the phase of menopause or perimenopause you're in. Black cohosh, not a lot of, it's inconsistent evidence there and could be impactful in causing some adverse effects and having interactions with medications. It too can increase estrogen, keeping that in mind. So it's about when it's actually introduced in the management of hormonal symptoms. Vitamins and minerals, we're going to go over those a little bit, but certainly my favorites are omega-3s, fish oil, flaxseed, chia seed oil, and magnesium. I think on my next slide might actually include those. And actually, it looks like it's going to be a duplicate of a slide. Looks like what's coming up. Acupuncture, another thing that I've introduced myself, very good at managing hot flashes and insomnia and the angst or the anxiety that comes along with menopause. Want to make sure that we emphasize that there are things to consider, and you should consult your primary care provider about using any of these measures or whether or not they're going to be a great fit for your transition through menopause. All right, so that's actually a duplicate, and that's actually was the repeat, it looks like, of that slide that shows those non-hormonal prescription options. All right, that's the same, excuse me for that, duplicate. And there is a time now for questions. I did want to, and I thought I had it in here, but I told you about magnesium as an option. I had an additional slide that I was going to include, but it actually listed those magnesium levels, dosages or types out. So magnesium glycinate is a common magnesium that we use for menopause, or for insomnia and hot flashes. And then there is a magnesium L-threonate, one that I actually use, that's good for the calm and chill, and also good for sleep and hot flash regulation for me. And then the healthy fats. So that's what we find in avocado and salmon and tuna, and mackerel, flaxseed, chia seed. You want to make sure that those are at the levels of about 2,000 to 4,000 a day. For most, that usually works well at helping to have some building blocks for those hormones that we're having a challenge making. All right. So let's see here. I'm going to move this back a second. And it looks like we have a few minutes, maybe about 10 to 12 minutes that we can open up for some questions. And actually, this is a QR code that if you wanted to schedule an appointment to talk more about your hormone symptoms, you can do that. And I think, let me go back to that screen because I do want to see if there is actually a spot to introduce questions. And so I'm going to ask our moderator if that is an option for people to do.
Yes, you are able to use the Q&A button at the bottom of the screen to do any questions, or if you would like to write them in the chat.
Excellent. Thank you for coming off mute to do that. Yes, and so I just now have accessed that chat. So if you have questions, feel free to pop them in, and I'll take a minute to go over those. And so now reading some of the comments in the chat. So yes, that body odor is terrible. I have gone through many different deodorants and have found a deodorant salt, I think it's called, that I found at Whole Foods that actually has been helpful. And I think it was actually a phase. It doesn't last forever, but it was a phase that I was going through that left a lot of sweating and body odor. I hate to say. Hopefully you haven't experienced it. You smelling me, that is. All right. So yes.
You have
We
any
had
questions that came through the Q&A?
yes. And I'm not sure if I'm seeing those. Do you mind reading it out for me?
Happy to. This one says, I had a total hysterectomy last year at age 47. I still have my ovaries. How do I know when I have actually entered into menopause?
Right, that is a challenge because you don't have that menstrual cycle to determine, right? So in many cases, we can check blood work to see if your FSH and LH levels have reached that threshold of being in the menopausal phase, but having a conversation with your provider about whether or not your symptoms are representative of being more estrogen depleted or progesterone depleted, right? So there's some symptoms that are more estrogen related and some that are more progesterone related, and we can help you tease that out. It is a challenge when you are without a menstrual cycle for guidance. There are some things that though we can still use to help mitigate and manage some of those symptoms. All right. And let's see, do the symptoms resolve after you go through menopause? Yes, those there are phases, like we showed you that range of symptoms that are depending on where your hormone levels are, depending on what age you are. So yes, you go through phases of symptoms. There's a perimenopause phase, and those symptoms shift to when you're in menopause, and then they shift after you get settled in the menopause and transition through to a couple of years outside of menopause, being in that postmenopausal phase. There are some women, though, that have hot flashes into their 70s, unfortunately. There are plenty of women, though, that continue to have insomnia all the way into their 80s, unfortunately, ladies. Unfortunately, there are ladies that are still having insomnia. Now, many of those, I will say, are not doing much to manage their symptoms because you have to keep in mind that there was a period of time where there was limited options around management of symptoms for people, especially around hormones. So there are many of options that we can do to help manage symptoms individually or hormonally. So some things that could be non-pharmacologic and some things that are hormone related. And so Are there any studies out there on hormone replacement therapy after breast cancer if in remission for over 5 years? Yes, so I actually had this discussion with a patient earlier this week around breast cancer risk and hormone replacement therapy. There are some women that are candidates for testosterone supplementation to help mitigate and manage some of their hormonal symptoms, but still there's lots of controversy around hormone replacement therapy with estrogen and progesterone during after their postmenopause or after their breast cancer of any duration of time. I do have some women who have gone back to their oncologist to have a discussion about if they're at a point in time that they have been outside of the window of hormone of a breast cancer that may open up some options for them around hormone replacement. And that's a very individual depending on what type of breast cancer was determined that patient was determined to have. One of the things that even people with breast cancer can do, because it's not systemically absorbed, is vaginal estrogen. So they can help take care of some of the vaginal symptoms around menopause. So that is something that is truly on the table for all women of all ages and whether or not they've had breast cancer or not. Then we have another question here. I have had a marina for the past 10 years. It's helped to manage my heavy flow, which is a great way to transition through that perimenopause phase. I'm considering taking it out. Have you heard of a cycle returning heavy once removed? Depends on where you are in that perimenopause menopause journey. So those heavy cycles typically occur in that perimenopause phase. So that perimenopause phase of that estrogen going up and down with the progesterone is a common time for heavier cycles. If that is still a phase that you're in with that marina in place, it could very well be that those cycles return. It truly depends on where you are in that phase. I've had some women have another marina put back in if they're still trying to transition through that perimenopause to menopause phase of their life. But the marina is a great way to ride out that because it gives you some additional progesterone. And as I said before, progesterone is one of those hormones, is that hormone that drops first in that hormonal transition. So certainly very individual. Hopefully that gave you some guidance. And I do have a lot of women with a marina in place to ride out those hormonal symptoms around perimenopause and menopause for that matter too. All right. And let's see, any other questions? I think we're coming to the end of our time, and it's been wonderful spending it with you this evening. Being able to share a little bit about my hormone perimenopause menopause journey to give you some insight of how it maybe can help you manage through this challenging time. And I would certainly say it's challenging. It can be very much an emotional roller coaster for many people. Keep in mind that we do have another webinar coming up on the 24th of September. And that is, if you haven't registered, please do, so that we can share more about metabolism, right? That's a major one. I felt like it wasn't not going to be enough for me to do it justice by adding it into this seminar today, but we're going to spend the majority of the seminar on the 24th talking about metabolism and how do we manage through that menopause, perimenopause transition with that. Great. Thank you. This is one of the things that I'm certainly passionate about because I want to empower women to know that they have the ability to manage or improve their symptoms. It doesn't have to be miserable. We have ways that we can manage our symptoms. And you're not alone. And you're not crazy. That was the other thing that I thought that I'd lost my mind. Great. I do thank you for your time this evening, and I look forward to seeing you on the 24th. Great. Thank you, ladies and gentlemen. I think one of the next ones that I'd like to do, y'all let me know, give you a chance to think about it. But I think we need to bring some guys in the conversation because I think we need to, we need to educate them on what we're experiencing so they can have a little more of an understanding about that I'm hot and you're not. And because you're not doesn't mean that I'm not hot. Yes, I think that's a conversation we should have. Great. Thank you so much. And I am going to conclude the seminar. Thank you so much.